Ladies and gentlemen, President of the American Society of Clinical Oncology, Dr. Peter Yu.
Good morning. Good morning, everyone. It's my true pleasure and privilege to introduce our guest speaker, Professor Michael Porter. Professor Porter is recognized worldwide as the father of the modern strategy field, which applies strategic thinking on the nature of competition to systems ranging from business, environment, developing nations, and healthcare. He has been identified in a variety of rankings and surveys as the world's most influential thinker on management and competitiveness. He is the Bishop William Lawrence University Professor at Harvard Business School and the founder and director of Harvard's Institute for Strategy and Competitiveness. Our distinguished speaker graduated with high honors in aerospace and mechanical engineering from Princeton University, received his MBA with high distinction from the Harvard Business School, and a PhD in business economics from Harvard University. He has taught generations of students at Harvard Business School and across the entire university, as well as business, government, and healthcare leaders from around the world. Dr. Porter has been a strategy advisor to leading U.S. and international companies, served on Fortune 500 public boards, and played an active role in U.S. economic policy at the federal and state levels. He has worked with heads of state from around the world on economic development strategy. Michael Porter has founded or co-founded 4 nonprofit organizations growing out of his scholarly work. The Initiative for a Competitive Inner City, which addresses economic development in distressed urban communities. The Center for Effective Philanthropy, which creates rigorous tools for measuring foundation effectiveness. FSG, a leading nonprofit strategy firm serving corporations, NGOs, and foundations in improving social value creation. And the International Consortium for Health Outcomes Measurement, which develops patient outcome standards and risk factors by medical condition and drives their adoption globally. Professor Porter is the most frequently cited author in business and economics. He is the author of 19 books, including Competitive Strategy, Competitive Advantage of Nations, On Competition, and Redefining Healthcare, which is my favorite, as well as over 125 academic articles. He has won many scholarly awards and honors, including the Adam Smith Award of the National Association of Business Economists, the John Kenneth Galbraith Medal, the David A. Wells Prize in Economics from Harvard, and the Academy of Management's highest award for scholarly contributions to management. He is also an unprecedented 7-time winner of the McKinsey Award for the Best Harvard Business Review Article of the Year. Professor Porter is the recipient of 21 honorary doctorates and several national and state honors. He received the first ever Lifetime Achievement Award from the U.S. Department of Commerce for his contribution to economic development, and has been elected an honorary fellow of the Royal Society of Edinburgh and other honorary societies. In 2000, he was named a university professor by Harvard University, the highest recognition that can be awarded to a Harvard faculty member. Please join me and give a warm welcome to Professor Michael Porter.
Wow. Oh my gosh. Well, I can't do anything but go down after that, Dr. Yu. Thank you so much for that very generous introduction. And it's truly a great honor and a thrill, frankly, for me to be here today. Dr. Yu didn't say this, but for about 15 years, I have devoted a substantial part of my time to actually thinking about healthcare. And in particular, the delivery of healthcare, what many of you do every day. I'm honored to be at this meeting because there's so much talent and energy in this room. You know, the best and brightest of not only America, but countries around the world are here today. Oncology has accomplished so much. Things are getting better. Science is improving. Technology is improving. Clinical care is improving. And that's great. But healthcare remains one of the great unsolved problems in the world from the point of view of healthcare systems. Costs are rising out of control almost everywhere in the world, not just here in the US. We have extraordinarily expensive technology being developed, but a lot of it doesn't seem to move the needle that much in terms of what the patients really care about. We've got extraordinary pressures on reimbursement now that are a reflection of so many years of cost increases that all of you that are clinicians are feeling more and more acutely every day. We've tried a lot of things to solve the healthcare problem. We've tried evidence-based clinical guidelines. We've tried prior authorization. Many of you have to live through that. You want to treat a patient with an expensive service, you have to get somebody to approve in some office, in some other place. We've tried asking the consumer to pay more and more of the cost of their care with the theory that that is somehow going to make them the drivers of some kind of change. We've added care coordination. We've tried lots of incremental solutions with great energy, but none of them have actually made any significant difference whatsoever. Little bits of improvement, but no fundamental change, no fundamental shift in the path that we're on. This problem of how to change this trajectory of the healthcare system is one of the great problems of the world. That's why I just cannot stay away from it. And also it affects everybody's lives. What I'd like to tell you, though, is that after many, many decades of false starts and lots of hard work that didn't ultimately turn out to matter that much, I think at this particular moment, we are starting to see a very clear path forward. Now, I think many of you in the cancer field may not quite feel this yet, but we're seeing a path forward that's spreading very rapidly in clinical organizations all over the world. It's a path that seems a little bit scary at the beginning because it's a very different way of doing things, but it turns out to be practical. It's happening. People are doing it. And we are starting to see the results, not on a systemic level, but on the level of individual providers in individual areas, for sure. And these results are not incremental. We're seeing step function improvements in outcomes for the patient. And we're seeing substantial improvements in cost, the cost of actually delivering the care, on the order of 25 or 35 or even 40%. And I will tell you, all of you sitting in this room, you can achieve that level of improvement in your practice. And those of you here in the pharma industry, you can make that level of difference with your products and with your services. But in order to do that, we've got to step back and have a really fresh new way of thinking about healthcare delivery. And it's a little odd that a non-physician from Harvard Business School is standing up here talking to you about this. You are the experts on healthcare delivery. But what I've been able to bring to this discussion is a perspective of how to think more holistically about delivery as a science. How to think about management, organization, measurement, in ways that I think when they get combined with this remarkable medical science, that is being developed literally every day is allowing us to see this different path for how to actually deliver health care. We have limited time this morning, but what I'd like to do is give you sort of the essential ideas about this new path. And I'd like to invite everybody in this room to get on it, if you're not already on it. The society has taken some constructive, positive steps in this direction, but we can do so much more. And if we do, I promise you, based on everything I know from all the work I've done in so many fields over my career, this is going to work. So how do we look at healthcare differently? What is this new path? Well, I think the new path to transforming healthcare is to get extreme clarity, first and foremost, on what is our goal here. What are we trying to achieve? Healthcare has been, frankly, a little bit diffuse in terms of how people think about the fundamental goal. There's lots of different goals that one hears healthcare organizations and healthcare practices espousing. But the only goal that makes any sense is value for the patient. What's value for the patient? Value for the patient is the health outcomes that we can achieve for that patient. The outcomes, particularly, that matter to that patient. And the denominator is how much it actually costs us to actually deliver those outcomes. This is the fundamental purpose of healthcare, to deliver great outcomes and to do it with increasing efficiency. If we're improving value, if you're improving value tomorrow in your practice, you are succeeding. If value isn't going up in your practice, if you're not improving value, frankly, you're failing. Value is the fundamental purpose of healthcare, and it also has the advantage of being the goal that we can all agree on. Clinicians can agree on it, patients can agree on it, payers can agree on it, health systems can agree on it. We've got to get on the path where this is what we get up to do every day. Significantly, relentlessly improve value. And the question, of course, is how to do that. This is the big question of our time in healthcare. How do we actually organize ourselves? How do we measure ourselves? How do we get paid in ways that support and encourage and enable the substantial, dramatic improvement of value? This is the question that I'd like to spend the time I have with. Now, in order to, I need to go back. In order to think about value, the first key idea is that we can't understand value for a hospital. It doesn't make any sense. There is no value for a hospital. The value for a hospital is lots of different patients with lots of different needs and lots of different clinicians providing lots of different services. We can't measure the value for that. We can't understand the value for a hospital. Let me say something a little more provocative. We can't measure the value for an oncologist. Yes, you do important work in cancer care, but you're not the only one involved. And your work is not the only work. There's a lot of other services and steps involved in care for most cancer patients. And to measure value, we can't just look at your piece or your surgery, or if you're, there's not many surgeons here, but if you're a surgeon, we've got to look at the condition, the overall condition of the patient. We can only measure value for the condition. And the way I talk about condition is for things like breast cancer or diabetes or sort of other medical circumstances that are often multidimensional and they involve multiple pieces. In breast cancer, for example, there are lots of different varieties of breast cancer, but we need to learn how to think about value around care for breast cancer, or care for lung cancer, or care for head and neck cancer. When we think about it that way, we can measure outcomes. How did that breast cancer patient do? What matters to a breast cancer patient in terms of outcomes? And we can think about the cost. If we add up all the cost of all the interventions and all the services we're provided over the whole cycle of care for breast cancer and compare that to the outcomes, then we have the magic data that we need to truly understand value. But as you all know, we don't look at it that way today. First of all, we don't even know what the outcomes are in 99.9% of the circumstances. And we don't measure cost the way I just described. We don't add up all the cost involved in the care of an individual patient over their journey. Virtually no healthcare providers that I know actually know that number. And as a result, we've been operating blind to a considerable extent. If we don't know the outcomes and if we don't know the cost, how can we actually maximize value? And the answer is we can get better. The people in this room are incredibly talented and incredibly smart and incredibly hardworking, but ultimately without understanding how to think about it and actually measure how well we're doing, our progress is slowed down. So we've got to focus on value. We've got to think around value around conditions, not our specialty, not our intervention, not what service we provide, not what site we're at, not whether it's in hospital or out of hospital. We've got to think about value for the whole cycle of care. And the question is, how would we change the way we actually deliver care and pay for care and measure care in order to do that? And we believe the answer is contained in really 6 fundamental strategic agendas that every healthcare delivery organization must adopt. There's no other way to move to value from the work that we've done in this field. What is that agenda? Well, number one, we've got to reorganize the way we deliver care. The first principle of organization is that when you organize, you don't organize based on the tools or what you do. You organize around the need that you're trying to meet. The first and most complicated change that has to happen is we've got to reorganize around the patient and around the condition. We've got to move away from the current specialty intervention-based, site of care-based organizational structure. It's the only way. We'll talk about that in a minute. Number two, we actually have to start to measure. Every day, all the time. We can't just rely on clinical trials that are sort of somewhat artificial circumstances for our data on outcomes. We have to actually start measuring outcomes by condition. And we have to start tracking the cost. We have to know how much we're spending. We have to keep track of that. That's going to require some changes in how cost accounting is done in virtually every delivery organization that I've come in contact with. But unless we measure, we'll never be able to bend the curve, as people are fond of saying. Number three, we have to get paid differently. A lot of oncologists have done pretty well with fee-for-service from an economic point of view, but it doesn't make sense from a value point of view. And it doesn't reward us, those of us like you who are delivering care, it doesn't reward us for actually delivering value. In fact, it rewards us for not delivering value. Because if we do more and it's more complicated and go slowly, we get paid more. So you have to start becoming advocates for a new payment model. And we'll talk about what that payment model needs to be. Instead of obstacles to the new payment model, which is what too many physicians around the world continue to pursue. We've got to change the way we get paid. Number 4, the whole concept of a healthcare delivery system must change. We have many wonderful systems in this country delivering a large part of care where there are multiple hospitals in the system, multiple sites of care, and multiple outpatient units, and they're not real systems. All the entities in the system, all the hospitals offer pretty much all the services. We're not getting the right services to the right locations. We're doing simple stuff in academic medical centers and complicated stuff in community settings where we really have no hope of delivering value. We've got to aggregate volume. As we'll see later, volume is really important if you want to deliver value. You've got to have enough patients of a given type with a given set of issues in order to have the right organization structure, in order to have the right team, in order to really get the benefits of measurement. So when we talk about systems, we got to kind of restructure here how we think about a system. Everybody can't do everything. We've got to aggregate care to 1 or 2 sites in each area. We've got to start working across the silos that a system represents if we're going to ultimately deliver value. Well, number 5, we've got to get away from the localized model today that is predominant in healthcare beyond just the some few academic medical centers. We've got to, excellent organizations need to stretch across geography through not only ownership of other facilities, but also affiliations. Affiliations where we develop a relationship where we work together with a center or with an expert in the particular field in order to deliver care for that condition. And finally, we need to put in place the right IT infrastructure to sort of that we have the data, that we can aggregate the data so that we can do the measurement efficiently, we can understand the cost efficiently. And all of you know that the IT systems are getting much better. You know, meaningful use has helped. But we have a long way to go before we kind of get all that infrastructure aligned with this model. So let's take a minute and focus really on the first 3 of these areas and dig down a little bit and talk about what does this really look like? What does a value-based delivery organization actually look like? And if we can understand that, I think we can start to think about, how do we actually get there? Now let's talk about care organization. The traditional model of care, you all know better than I. And this is still a model that's predominant across America for sure and in many parts of the world. It's a model where we were organizing ourselves in a logical way around specialties and individual services. So think of these yellow bubbles, each of which is a separate entity: a medical oncologist, a surgeon, a dentist, a pathologist, and we could, for head and neck cancer, we could have 15 or 20 more yellow bubbles. This is a simplified view of all the entities that might get involved in the care of this kind of a patient. And the traditional model is every service, every expert is their own bubble. And the patient is the ping pong ball. The patient pongs from bubble to bubble in a semi-random order, stretched out over time. Each pong involves a separate appointment. Each pong involves a separate administrative interaction, a separate clipboard, a separate waiting room. Every bubble, by and large, tends to see all kinds of patients with all kinds of problems in their field. So a medical oncologist will see all kinds of cancer. They'll see some breast cancer and some head and neck and some lung and some this and some that and sort of pretty much any cancer that is out there, they'll see it. They'll deal with it. This process stretches care over long periods of time because it's inherently slow. This process is impossible to coordinate. If this is the way you're organized, if you're all in separate places, if you're all kind of doing your own thing on multiple types of cancers, No way to coordinate. There's not enough time in the day. What we've come to believe is that this model might have worked 50 years ago when there wasn't much technology, where you could master everything in your field, where you would know all the drugs, you would know all the therapies. Maybe this might have worked. It won't work today. It's impossible. No matter how hard the clinician tries, no matter how hard they study, no matter how hard they work, no matter how hard they care, this model cannot deliver value. It's impossible. It can't deliver the best outcomes except by luck or by chance or by good fortune. And it for sure can't deliver the care efficiently. We've got to change the structure. As comfortable as we all are with the way it is today, because we've done it for years and years, it hasn't changed in 50 years. We've got to change it. And where we have to change it is clear, although it's not easy. We have to create around each condition or family of related conditions, we've got to create what we call an integrated practice unit. Rather than having the bubbles, we've got to put the key skills and the key specialties required to deal with that condition in the same organization. They need to work together, not separately. And this team, which you see in the middle of this chart, in complex problems like head and neck cancer, is going to be a pretty big team. And ideally, that team is going to be co-located. Now, they may not be co-located, but at least they should be virtually co-located and work together in a virtual way through repeated relationships and interaction over time. There's going to be some things that team then does themselves. Occasionally, they'll call in specialists that are not the people that are normally involved in the head and neck cancer case. A lot of head and neck cancer patients are going to need some plastic surgery. There may not be enough of that to have the plastic surgeons in the team every day or 2 times a week or 3 times a week. But whenever we call in a plastic surgeon, we just don't call in the random plastic surgeon to consult with a head and neck cancer patient. We call in the plastic surgeon that gets to know head and neck cancer patients, that gets to know their issues, that gets to know the complications of how to actually do plastic surgery for these kind of patients given what they've gone through. So to the extent that we don't have people on the team, the people that we bring in are not just random people that happen to have time on their schedule. They're people that actually have a demonstrated interest in this problem, in this disease, because it's complicated. There's no way a plastic surgeon can figure all this stuff out for any disease or any problem that crops up. They've got to learn stuff. It's complicated. And of course, this team is going to share some facilities. Chemotherapy administration is probably going to be combined across cancer types. It is in MD Anderson. Operating rooms are not going to be dedicated to individual cancer types. They're going to be shared. It's going to be shared resource. But the core of delivering value is that the expertise and the critical specialties that are necessary to manage that care cycle are really working as a team. This is where we have to go. We can do it in community settings as well if we're clever and thoughtful about how to make sort of virtual versions of this. But we have to move in that direction. The way we're doing it now just can't work, no matter how hard we try. Now, part of this notion of an IPU is about the whole care cycle. It says, no, just being the oncologist and doing the chemotherapy, that's not enough. We're not finished if we just do that. We can't check out just after we do our thing. Successful care for virtually every condition involves a care cycle. This example is a historic picture. It doesn't look historic, but it is. It's a shoulder surgeon in the front of the room meeting on a Saturday with a whole bunch of outpatient rehab staff. These are private practice people. They are not owned by the hospital. This is actually at the Brigham and Women's. You know, this never happens. The surgeon does a wonderful rotator cuff repair. Make sure the patient, recovers okay. The patient leaves the hospital, and then the surgeon's done. And they're not involved in any way in what happens next. Well, this is a historic, different approach, where the surgeon says, look, we've got to make sure by getting to know and building relationships and providing training, we've got to make sure that those outpatient rehab people know how to handle this problem of rotator cuff. Because if they don't, the good work that we did won't actually deliver value. This is the new way we have to think about healthcare delivery. We can't hand off. We can't be done. We have to be part of a team that jointly accepts the responsibility for the whole process of care. And that's as true in cancer as it is in any other field because of the complexity, because of the sheer number of things that need to go into excellent care, including support services. Swallowing therapy, speech therapy, nutrition, social work to deal with depression. There's all kinds of stuff that determines whether you actually succeed. Those of you sitting in this room. And you've got to take responsibility for those things. And we've got to create organizational structures that allow us to do that. And when you do that, you will find that the results improve dramatically. And you will find that the cost improve dramatically. That's what we're learning all around the world. That's what we're learning. Now, this slide I'm not going to cover, but this is sort of a checklist for what is an IPU. I'm not going to go through these things, but I don't want you to be intimidated by this. I don't want you to say, oh, we're just a community setting practice, we can't do this. No, 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 you can do this too. You don't have to own everybody that's part of the team, but you need to work together. You need to meet once in a while to talk about your patients. Or whether you're a relatively smaller community practice. And you need to start creating alliances and affiliations with other practices, perhaps, to be able to pull this off. But in order to deliver value, another key thing we need is we need some volume. We need enough volume of patients with this problem, breast cancer, or whatever, in order to actually build the team. Now, the team doesn't have to be full-time. We can have a team for 2 days a week. That's fine. We see lots of examples where we dedicate a couple of days a week to a particular condition, and then we dedicate another couple of days a week to another condition. That's fine. But we got to have enough volume of people that we can have at least a couple of days worth of patients every week or every other week. But what's happened in healthcare, particularly in America, but again, I see it all over the world, is we've fragmented our volume. Everybody does a little bit of everything. Everybody does a little bit of everything. Nobody does a lot of anything. And you look at these numbers, I mean, and this is not condition numbers, these are surgery numbers. But look at, how many patients in America are getting care by surgeons that just haven't done enough cases to deliver that care well. And there's no doubt about it in terms of the medical evidence. And frankly, the volume is even more important if you have the integrated practice unit or IPU concept. This is volume based on pure surgical experience and technique and all that, but volume is even more important if you talk about having the team and wrapping around the support services. So we've got to aggregate some volume. And that means we have to start thinking much more carefully about where we do what and who does what in terms of what we're trying to care for. 50 years ago, a medical oncologist, given this current state of drugs and the current state of knowledge and the current state of technology, maybe a medical oncologist could handle pretty much anything that came in the door. Today, I would challenge you that that's really hard. It's even hard to figure out what's going on in breast cancer, just one. Given all the variants of the disease, given all the genetics and the immunotherapy and all the stuff that's going on. So we have to shift the way we think about what we choose to do and who we choose to do it with if we're going to ultimately deliver value in healthcare. You know, I know that ASCO has the COPE certification. And the COPE certification was a big step forward. And I congratulate ASCO for taking that step. But all of you know what COPE certification is. It's, did we assess pain by the second visit? Do we have a documented plan? Have we documented smoking cessation status? Those are COPE criteria for certification. Those are good. But gosh, we've got to raise the bar. This example I'm showing you here about breast cancer, this is what certification needs to be. If you're going to be certified, you can't just document smoking cessation. You've got to have a minimum volume of cases so that the team has experience and expertise. You know, we've got to have people on the team spend at least enough time on this disease so that they really learn it. We need a leader. We need to get together and meet regularly to talk about our patients so that we can have coordination. We need to take responsibility for the whole pathway, and we have to measure. So I'd like to challenge ASCO, let's push certification to the next level. Let's move away from just a few process guidelines and really start thinking about value at a more fundamental level. Now that leads me very quickly to the whole issue of measurement. And again, time is short, but I think all of you know that we have started measurement of quality in healthcare, but overwhelmingly quality measurement so far is about compliance with guidelines. Now, in my humble opinion, compliance with guidelines is not quality. It's a good process. The only thing that defines quality in healthcare, really defines quality, is the outcomes. The results the patient actually achieves. And whether the outcomes that matter are getting better over time. We've got to take the leap to outcomes. Now, of course, cancer has long focused on survival. And that was obviously the place to start. And survival in cancer is so epically important, given that this is such a challenging and deadly disease. And so I'm not saying that we should stop measuring survival. What I am saying is that's not enough. That's not enough. And we're doing better on survival. And we can now start putting our attention not just on survival, but on all the other things that matter to the patient, of which there are many in cancer. Now, in order to think about outcomes, we've developed some tools and frameworks. One of the key ones in the outcome area is what we call the outcomes hierarchy, which says that first of all, you've got to measure outcomes by condition. You can't measure them by specialty, by hospitals, by sites, by condition. Breast cancer, lung cancer, whatever. That outcomes are multidimensional. They include survival, but they also include functional status. They also include the nature of the care process that the patient was put through. its timeliness, its complications, its pain, its suffering, its et cetera. And outcomes also include really what we call the sustainability. How long were we able to provide a better outcome before there was a relapse or a recurrence, which is obviously a big deal in your world. We've got to learn to measure the whole hierarchy of outcomes, or at least enough pieces of it that we can actually see and measure how well we're truly doing on all the things that really matter for the patient. Here's an example of an outcomes hierarchy for lung cancer. Could you measure more? Yes. But this set of outcomes was designed to be a minimum set of outcomes that everybody should measure. And then if you want to measure more, go ahead. This set of outcomes was developed by this organization called ICHOM, International Consortium of Health Outcome Measurement, that Dr. Yu mentioned in my introduction. We formed this organization with a number of partners, and many people in this room, I think, are probably involved, to define standard minimum sets of outcomes, condition by condition by condition. In this particular case, there were 19 distinguished clinicians, including one or two patient representatives, from drawn all over the world, that spent 6 to 8 months sorting what you really need to measure if you want to measure the success in lung cancer. And you can look down the list, and obviously this presentation is more than available to you after this session. If we can start to move from process to outcomes, if we can start to track this data systematically and regularly, if we can, of course, risk adjust it, which is also necessary, we're on the way to a whole new era in your field. I've seen this in other industries. I guarantee you, if we can start to do this, it will be transformative. And it will allow you to truly feel like you're succeeding as much as you could and accelerating progress as fast as you could. Why do we need to measure more than survival? Cancer has been really locked on survival for a long time. Well, here's a good example from prostate cancer. This is data from Germany. Some of the best value work we see is going on in Germany or in Sweden or in Taiwan or other countries. I know there's many international people in the room. I don't want to make this seem like the U.S. is the center of value. It's not. But it's getting better. In prostate cancer, just about everybody can come up with a pretty darn good 5-year survival. The best hospital and the worst hospital are pretty much the same, or the average. Are we done if we achieve 75% 5-year survival in prostate cancer? Well, no. Because what really matters to the patient is they're assuming they're going to survive. They're hoping, but they're also assuming. And they're interested in some other critical things about their functional status, about their quality of life. And when we start looking below survival, we see tremendous variation in these areas on the screen. And that's because we haven't been measuring these kind of things. We haven't been really focusing on, how do we get better at this? Yes, of course, we're trying to get better, but to have the rigor and the evidence and the innovation going on there has been less than it could have been. Let me just conclude this section by telling you that when we actually achieve outcome measurement anywhere in the world that's systematic and standardized, amazing things happen. This is the one case in America of a substantial major condition where we do have universal standardized outcome measurement in organ transplantation. You all know this case. And it happened because of NOSA and the organ system and the requirement that you measure if you're going to get membership in the organ system. And this was the first data set This looks at one outcome measure, 1-year graft survival, and all these dots are the 219 kidney transplant centers in America that existed at that time. This was the first data set. It's reported in 3-year increments to aggregate enough volume to kind of make it a little bit more statistically valid. There's a regression model for risk adjustment built in that has been developed by some really smart people and is well respected and continually improved. We've done outcome measurement systematically in kidney transplantation. Everybody does it. Everybody does it. You know what happened? Well, what I'm going to show you now is the latest data set on this same measure. That's what happened. When we commit to systematically, in a standardized way, religiously measure every time, where that data is available and transparent enough that people can see who's doing well and learn, amazing things happen. I could show you 20 pictures like this from all over the world. It always happens, every single time. We have to aspire to do this in oncology. We have to get this done. And you can. And people are doing it. And it's satisfying and rewarding when you do it. But our natural reaction is, well, I'm not sure I want to do this. What if I look bad? It's a lot of work. Maybe the risk adjustment isn't perfect. There's a lot of excuses for why we're not doing this, but we have to get over this and move. And we will. In terms of costing, costing in healthcare is a very complicated issue because of the way we've traditionally gotten paid. The fee-for-service system has caused us to think about cost really in a flawed way. What we normally measure when we measure cost is we measure actually our charges, not the actual cost. The cost is what it actually cost us to deliver the care. And the only way we can understand that is we've got to map our processes. This is an example from Boston Children's. I won't even attempt to measure the condition, to say that word. Every time I try, I fumble it. And this lays out what is the care process, what are the protocols for that condition. Who's involved in that care? Physicians, nurses, technical staff, OR staff, who's all involved? How much time is everybody involved spending with that patient in that care process? What are the facilities and equipment that are involved in that care process? The way we must understand our costs is we've got to start mapping our processes and understand those elements. And organizations are starting to do this. There's now hundreds and hundreds of pilots underway about what this activity-based costing, as it's called, which allows you to really get high visibility of, okay, where you're spending your money, and are you comfortable with that? We're on our way, but again, we got a long way to go. But ultimately, if you're going to understand your cost and figure out how to deal with lower reimbursement, you got to do this. There's no other way. You can't just guess. You can't just settle with the standard kind of departmental measures that people typically have, which really don't look at the care for a given patient with a given problem. We've got to get beyond this. And we will. But it's not easy. We're on the journey. When you have outcomes, and when you actually know the real cost, not the charges, but the real cost, then the magic starts. This is prostate cancer, or actually, this looks at 4 key outcome measures. This is a very interesting, pioneering study on a so-called spider chart. So if the line is farther out, that's good. And you can see there's a line for cost, 1 over cost. 1 over cost is good. Farther out is good, in is high cost. And you can see a number of different therapies for prostate cancer. And you can see how to compare them, how to understand value. And you can see that if you're a relatively younger patient and you've got a long life ahead of you, hopefully, you might actually opt for proton therapy because it does better on sexual function, urinary incontinence, and urinary bother. Doesn't do necessarily better on 5-year survival, but 5-year survival is high. On the other hand, for a lot of other patients that are maybe older, the cost advantage of brachytherapy is compelling, and it actually does pretty well in survival, but a little less good on some of the other measures. So this is the kind of evidence we need. This is the kind of data we need if we're going to truly deliver value. And we can do this. It's happening. It's underway. There's many examples. We need to do it in this field. We need to do it more. There's some people in this field that I know that we work with that are moving in this direction, but we have to move faster. And this just gives you some of the major cost reduction opportunities in the field. I know all of you are very concerned about the cost of drugs, these high-cost drugs that maybe produce only a little bit of benefit. But it turns out, best we can tell, that drugs account for only about 25% of the whole cycle of care in cancer. It's mostly people. It's mostly time and visits and other stuff. So yes, we got to make sure the drugs deliver value. And they can deliver value by saving the people time later on. But we also got to look hard at all the other stuff we're doing, all the tests we're ordering, all the expensive imaging we have done. Is it really necessary? Is it really contributing to better outcomes? Just because we get billed for it doesn't mean we should do it. Now, that leads to a final few minutes on reimbursement. How do we want to get paid? Well, I think what we're learning is that there's really only one way that you can get paid that actually rewards you and motivates you to deliver value, and that's what we call bundle reimbursement. A bundle reimbursement is really a single payment, often risk adjusted, for the care for a condition. Here's an example of a bundle. This is for hip and knee replacement in the county of Stockholm. This is the payment mechanism in Stockholm and increasingly Sweden for this condition. Now, this is not really a condition. This is really more of a procedure bundle, but that's kind of a way station on the way to a broader condition bundle. This is really arthritis of the hip or knee bundle. You can see in the yellow box on top what's included in the bundle. Basically, it's pretty much everything that happens with a pre-visit and, to some period after the surgery and people have gone home. There's a care guarantee. If there are avoidable complications, the average rate of avoidable complications is built into the reimbursement number. But if you do have more than the average complication, you're going to end up eating the cost of dealing with those complications. And this is the way this system is set up. And what happened when they went to this bundle model in Sweden? Well, first of all, as you see here, complications went down. Why? Because you were accountable for complications and people just paid more attention and focused on it. And there's been some remarkable improvements in complications. Functional outcomes stayed the same. Length of stay went down because there was no reason to keep the patient in the hospital any longer than they had to be and get them out. And they figured out how to make them succeed because functional outcomes didn't go down just because the length of stay went down. Volume shifted away from full-service hospitals to more specialty or community-type settings. The way they risk-adjusted this bundle was ASA 1 and 2 patients. These are fairly healthy patients, In Sweden, this was about 65 or 70% of all the people getting hip and knee replacement were relatively healthy. That's a testament to the health of the Swedes. And they didn't need to be in an academic medical center with an ICU and all that stuff. And if they needed to get to one, they could get to one very quickly in the case of this condition. What does this kind of payment do? It says, if you deliver good value, you meet good complication rates and good functional outcomes, you do well. If you can be more efficient, you do well. And more advanced bundles that are rolling out also include performance payments. This is a spine bundle in Sweden that rewards you if the patient's pain improvement from pre-surgery to 1 year after is better, is good, then you get a bonus. That's where we're heading in terms of payment. Now, cancer is complicated. Cancer is very complicated. I think the bundles in cancer are just starting to roll out. MD Anderson has a new bundle in head and neck cancer. I urge you to read about it. I think we're also starting to see bundles for diagnosis and treatment plan, so for that phase of the care cycle. We're going to start to see bundles for the chemotherapy. We're going to start to see bundles perhaps for survivorship, monitoring of survivorship. We're going to start to see people often take a piece of the care cycle or their piece of the care cycle and actually build a bundle around that. But over time, we will learn how to actually use this mechanism more broadly. And it sounds scary now, but I will tell you from all the experience I've had in all the fields that I've worked in medicine, that once you get there, once you get over the shock, it's actually a great way to get paid. Because nobody's telling you what you have to do. Nobody's telling you what you have to, what test you have to offer in order to get paid. You decide how to use resources efficiently and effectively to deliver the best outcomes. That's where we need to go in healthcare. Well, I've probably even gone over my time. We have to move to value. It's the only way we're going to have a good outcome in healthcare. If we don't move to value, we're going to have to ration care. If we don't move to value, all of you are going to take a pay cut. There's no other way. We have to increase value, or the outcomes are not going to be good for the people sitting in this room, or for the patient, or for our societies. In order to move to value, we've got to rethink the structure of how we work, of how we measure, of how we define success, of how we get paid. But the good news is we can. We know the path. This is the path. Organizations that are doing this are succeeding across many fields of medicine and in many parts of the world. We know the path. Let's get moving. Cancer is a huge area in medicine in every country in the world. It's a major cost contributor, and it's a fundamental driver of human beings' life and quality of life. We in cancer, you in cancer, need to lead this. Your previous value work has gotten you moving. We now have to move faster. If we can actually become a value-based field in this sense, imagine what healthcare could become. Thank you very much.